Well, great. I think we can get started. I see there are some attendees still dialing in, but I think we have a good number already started here. So good morning and good afternoon to everyone. Thanks very much for joining us for today's webinar. You may know this is part of a webinar series of the Lifecourse Research Network, or LCRN, which is hosted here at UCLA Center for Healthier Children, Families, and Communities, also funded and supported by the Maternal and Child Health Bureau. The overarching topic of the series is measuring health development of children and youth. The specific focus today is on data linkage. My name's Lisa Stanley. I'm the project director here at UCLA, managing our National Support Center in the US for the Early Development Instrument, the EDI. Some of you may be familiar. But my role today is to help host this webinar, which means I get to introduce our speakers and facilitate the Q&A. So before I introduce our speakers today, I'll just take a quick moment to provide some guidelines on webinar technology. I know many of you are already pros, but for those of you who aren't as familiar with this particular Zoom technology, I'll do that and then I'll recap where we've been with the past series, just to give a little context. So for the technical guidelines, just keep in mind during the presentation, all of the participants, all of you that have joined, you're automatically muted. But as a precaution, if you want to also put your mic on mute, you can do that. At the end of the presentations, we have 2 presentations. At the end, we're going to reserve 30 minutes for a Q&A discussion. And we hope that you will ask your questions and share your thoughts. You can put your questions in the chat box at any time. Given that there's a fairly large number of participants, I think that's the best way to do this, is to put them in the chat function. So unfortunately, if any of you have joined only by phone, you won't be able to use the chat. And so you could email us through the LCRN website. Also, I want to thank Jason Timmerman, our coordinator, for the technology. You can also email him at jmtimmerman@mednet.ucla.edu. That's jmtimmerman@mednet.ucla.edu. If you experience any technical difficulties, you can let us know through chat or emailing Jason. So to recap the topics that we've already covered in this series, we have had leaders and researchers join us from Canada and Australia, here in the US as well. Been talking about how they've been building comprehensive Lifecourse monitoring systems. So specifically, we've talked a lot about how 2 important population level outcome measures for children are serving as anchors to those monitoring systems, namely the Early Development Instrument, the EDI, which, as you may know, is a teacher-completed checklist for children around kindergarten 4 to 6 years of age. Also have talked about the Middle Years Development Instrument, or the MDI, which is a self-report questionnaire completed on 4th and 7th graders. So these webinars have also shared how communities in the US, Australia, and Canada are using these data to engage and mobilize stakeholders for collective action and improvement. So this is kind of where we've been. Today, our speakers are Kim McGrail and Anne Gadermann. They'll be exploring how to build capacity for data linkage. They will share some examples of child health data linkages taking place in British Columbia that are helping to create some groundbreaking Lifecourse data systems. Both our speakers are at the University of British Columbia in Vancouver. Kim is faculty with UBC Center for Health Services and Policy Research and is the scientific director of Population Data BC, among a variety of other positions. Anne Gadermann is an assistant professor at the Human Early Learning Partnership in the School of Population and Public Health and a research scientist at the Center for Health Evaluation and Outcome Sciences. So we're going to be able to take about an hour to hear from both of our speakers today, reserve 30 minutes for questions. So I believe we're starting with Kim. We can go ahead and unmute Kim's line and initiate the screen share for you. So Kim, are you ready to share your slides?
I sure am.
Wonderful. Well, then I'll pass this on to you. Thank you.
Thank you. And thank you for the introduction and for the opportunity to present today. I'm going to be providing a bit of a broad overview of access to data resources in our province of British Columbia, and then Anne will provide a more clear focus on the child health linkages and research and so on. So just to give you a sense of Population Data BC is the name of the research resource organization that I am scientific director of. And you can see here our mission really is, it's both a data and education resource, and it's really about being able to support interdisciplinary, multidisciplinary research on determinants of health, well-being, and human development. And we do this in the province of British Columbia, which has a population just a little under 5 million residents. We're the westernmost province in Canada. And perhaps important to say as well that we have a universal publicly funded healthcare system. Not 70% of our healthcare system is publicly funded, and also a universal other social programs as well. And this creates an opportunity to have population-based information for the entire province. So this is not subject to insurance coverage and so on. And obviously there's some details in there that I'm glossing over a little bit, but by and large, we are talking about population-based information. And so the ability to link these together creates enormous opportunities for research. And that's what I want to describe today. So Population Data BC works in this area, as I've said, as a resource, and we have 4 broad main functions. And these are what's pictured here on this slide: data access for research. We conduct data linkage on behalf of other parties as a trusted third party. We have secure data storing and archiving, and education and training to help people make the best and most appropriate use of the data that are available. And I'm going to go through and provide a little bit more detail on these pieces. So just to give you a sense of who we are based at the University of British Columbia physically. We really function, and this is why in our mission we talk about being a multi-university resource, because we do include in our governance people from all of our research-intensive universities in the province. We really do want to be positioned as a broad provincial-based resource. This is not something that's specific to people at the University of British Columbia. So this represents a number of different funders we have currently and have had over time. We've been funded through a combination of contracts or service agreements with government, because they are a major provider of data to us, but also through competitive grants that have both been for research and infrastructure funding. The Canada Foundation for Innovation, listed at the bottom there, really was a major funder in our early days. They provided us with the money that we use to create a physical, secure environment that really has been foundational to everything else we've been able to do. So if we think about why we built Pop Data, there's kind of 3 broad reasons for this. One is that we recognize that researchers were really, really interested in the ability to link different data sets together, including data sets that might come from different data providers. But this is really hard to do and not cost effective to do on a project by project basis. So the idea here is to do something once and then make it available to multiple researchers and multiple projects. So that's the idea of not making every researcher or push the rock up the hill every time they want to do a project. We thought from a data steward perspective. So if you think about data providers, the people who have responsibility over deciding about saying okay to data use, having a broad system in place and an organization that takes some responsibility for at least coordinating requests for access to data creates a lot more transparency for data stewards. So it's very clear when they're making decisions what the totality of a project is and the full set of data that researchers are going to be using to answer their questions, as opposed to just knowing about the specific request of a particular data steward's data. And then the third piece is the public. A lot of the data that we're talking about are administrative data, so they have been collected for other reasons, but have lots of research potential. This means that there's a sunk cost in those data, and I would argue an obligation to make as much use of those as we can for the public good, in the sense of using that information to provide better services, more efficient services, or more targeted services to areas or groups or individuals who need them. So in terms of what we have in British Columbia, you see the population number is floating around here. So at present, we have close to 5 million people in our province. Of course, we're a little bit behind that in our population coverage and our data, because the province's population is increasing all the time. So we have data, as I've already said, on everybody in British Columbia in one way or another. And of course, the amount of data that we might have about an individual will depend on both how long they've lived in the province and the number of different services that they've touched. And I'll come back and talk a little bit more about the particular data sets that we have, so I'll just gloss over that now. This is just to indicate that, of course, if you were a person who was born in British Columbia, we're going to have more information on you than if you just moved here recently, and we will have more information depending on how deep into service use you get from the public sector. Although the public sector service is not the full set of the data we have. It's a big portion of it. So here is a better picture of the kinds of data that we can make available for research uses. I'm just going through quickly on these. The health and healthcare services is a foundational piece. We did start as a healthcare oriented unit, but it immediately almost increased to that broader social determinants of health kind of perspective. And so there's lots of data in here on hospital use, physician use, pharmaceuticals, cancer registry, and that sort of thing. Then a second area for data is population vital statistics. So these would be both births and deaths, and as well as marriages, but also an important and central file that actually has demographic information for the entire province based on registration for healthcare insurance, which I've already indicated is universal. So this really is in the data linkage world, we would call this a population spine, because it becomes a full listing of everybody who is now or has been a resident of British Columbia, and therefore a good target linkage when we're trying to bring data sets in. That's that kind of is the ground basis of the ability to do linkage and then to do population-based research. On the occupational side, we have information from WorkSafe BC, which is our workers' compensation board, and that's both claims and firm level information. I'll come back to the childhood because that's a focus here. So the demographic and Lifecourse information, there's a large longitudinal survey of people who are healthy and aging. That was called the BC Generations Project. So this project includes surveys as well as actual physical measures, including blood draws from people. So that creates an enormous opportunity to think about longitudinal development over time. We also have the immigration data from our national federal agency, as well as some income band data from Statistics Canada. So this is our ability to create measures of neighborhood income. We don't have a great source for individual income at a population level, but this at least gets down to neighborhoods, which in Canada, because in a province of 4.8 million, 4.9 million people, we have 100,000 different postal codes. This is actually reasonably small information, certainly quite a lot different from zip code level information in the United States. And then the childhood perspective, we have information from Ministry of Education, as well as really the kind of crux of what this network is all about, and what Anne will be talking about, which is the information from the Human Early Learning Partnership on the Early Development Instrument and the Middle Years Development Instrument. So a wide variety of data that can all be linked together, subject to approval by data stewards. So I won't go into all of the detail on this slide, but this is really just to indicate that we have a full and formal data access process that really covers everything from the kernel of an idea from a research team through supports for data requests all the way to data access, supports for data analysis, and then following through to project closure. So it's really a full life cycle approach to data access. And all of this information is on the POP Data website in many different forms at an overall level and in more detail. We provide lots of services for data providers. I mean, obviously, we are here to serve research community in terms of data access, but a lot of this has to do with creating comfort and trust with our data providers, who really have to believe that what we're doing is going to be privacy sensitive and doesn't create risk for the individuals who are represented in all of these data. So this really comes down to the safe and secure data handling, the fact that we're a trusted third party to do data linkage. We operate a secure research environment, which I'll talk just a little bit more about later. And we also, as I've already indicated, have a full lifecycle management for data access, but also some tools that we've developed to help create a lot of transparency around all of these services and functions. So we do conduct data linkage at POP Data, and this really is just about the ability to identify the same person in different data sets and, of course, across time as well. And that's really all that's being depicted here. I assume that most of you are probably reasonably familiar, but if there's questions on any aspect of data linkage, I'm happy to answer them later. We have processes both, I've identified to you the data that we have, that we store either on site or that we have direct access to through arrangements, information sharing agreements with data providers. We have a process set up as well to be able to add external data in. If there's something that researchers want access to and the ability to link, we can do that. Clearly, we do that subject to all of the appropriate approvals and information sharing agreements and so on. But it is quite possible, for example, to negotiate access to a new data set from a provider of one form or another and to bring that in. And ideally, over time, what we do is if there's some value in that data set and lots of research groups might want access to it, we use that first initial linkage as a way to create a relationship and trust with data providers, and then ideally bring that into our holdings on an ongoing basis. And then we also have the ability to bring data in from a particular researcher. So if you've collected a survey or you have a clinical data set or something like that, we have processes in place to be able to enable linkage as well, which is how we've been able to support the linkage of the early development instrument in BC. And again, this is subject to appropriate consents and so on, but the process does exist. And we actually find that that external linkage or the bring your own data linkage is used in probably 2/3 of the requests that come forward to POP Data. So this is a very common pathway. We have very, very high attention to data protection and privacy, and approach this, for those of you who are familiar, there's an international standards organization, ISO, and they have a whole series of requirements covered under the 27001 rulings, and we follow those in spirit. We have not been accredited because the accreditation process is a whole thing unto itself, but we do meet those standards, and this involves physical, technical, and procedural measures to ensure security. I'm going to just skip over a lot of these details. Again, something I'm happy to come back to if people are interested, but I did want to hit on some of the procedural measures, which have to do with the fact that researchers make requests for access to data for a specific project and specific questions that will be for a time-limited nature. This is to be consistent with our Freedom of Information Protection and Privacy Act within British Columbia, and that means that only named researchers have access to data. They can be only used for the requested purpose. researchers have to go through privacy training and then sign confidentiality pledges, so it's clear what the expectations and responsibilities are that go with the rights to have access to these data. Things that are produced do have to be reviewed by data stewards before they can become public. This is not a public affairs review. This is just a review for accuracy and appropriate attribution. And data are destroyed upon closure of a project. The way that people get access to data once they're approved, and we produce a specific extract for a research project, and then we put that in our secure research environment, which is a virtual environment that people can access using two-factor authentication. So this is something you have and something you know. And these things are becoming, two-factor authentication seems now all of a sudden to be quite the norm, even with banking. If you've done banking online, lots of places are using that now. We have been operating our secure research environment since 2010, so it was relatively rare and certainly new in Canada when we put this in place. Our secure research environment is a Windows environment, so it will look quite familiar to any researcher who's using it. It provides secure storage and backup. It provides all of the software that people would need to do their analysis and to produce at least the major pieces of output. So the Microsoft Office suite is available in the secure research environment, as well as SAS and data and SPSS and R and Python and so on. And there's lots of monitoring and compliance assurances on our secure research environment. Researchers cannot move data in without approvals, and they have to attest to the things that they're taking out. For example, you cannot take raw data out of the secure environment, but you can take analytic results out. PopData also provides a series of education and training resources, and these are through a combination of means. So we have online things that are just freely available. We have in-person courses that are run intermittently that range anywhere from a day to a week. And we have a full online asynchronous population health data analysis certificate program that is geared to people who might already have some training in research and analysis, but really wanted to get a better understanding of the use of these kinds of complex linked data for their research. And like I said previously, all of this information is readily available on the PopData website, and I believe that is what I wanted to cover, at least in this first round. So thank you very much. I'll turn it over to Anne.
Great. Thanks so much, Kim. It's great to learn more about this resource. And I'm hoping folks, if as questions came up in their head, if you could go ahead and put them in the chat box. We will hold off on the Q&A till after we hear from Anne, but just it might be a good time to start jotting them down if you have them. So yeah, we'll go ahead and unmute Anne Gadermann and let you put on your screen. There you go. And
can you hear me?
Yes, we can.
Okay, perfect. Thank you so much. 1 second, and you can see the slides?
Yes, it's
perfect. Thank you so much for the opportunity, and it was great to hear the introduction from Kim as well. And so I will be talking about some of the examples that we have been doing at the Human Early Learning Partnership based on the linkage that gets provided by Population Data BC. So in terms of the agenda, what I would like to cover today, it's really giving some background on the population level longitudinal data linkage, some of the health and context measures very briefly. So these would be mostly the Early Development Instrument, EDI, and the MDI, the Middle Years Development Instrument, that were covered by previous webinars. I'll give some examples of research projects and then discuss some of the opportunities and challenges that we have faced. First of all, I would like to acknowledge Clyde Hertzman. He was the founding director of the Human Early Learning Partnership and a passionate early child advocate who had the foundational vision for this linked data monitoring system. So unfortunately he passed away, but this is really based on his idea. So in terms of Lifecourse trajectories, so we're interested in the beneficial and adverse experiences over the life course and how these differ and for individuals and how these are shaped. So the definition that was proposed by Clyde Hertzman and Tom Boyce was that these are distinct life course patterns of human development from the very beginning. And so what factors or combination of factors are associated with or shape these trajectories? And for example, are there certain windows of opportunity when one could best intervene to change a developmental trajectory that may be off course, for example? And you can look at different outcomes like health, learning, well-being, and behavior. And so we're actually looking at all of those in our research. And in terms of the population level longitudinal data linkage, we're using person-specific survey data and link these to administrative data through population data BC to really understand these different types of trajectories from a population level perspective. In terms of the theoretical framework, we're using the bioecological model of child development from Uwe Bronfenbrenner. And so you can see the child is seen within the multiple spheres of influence. So it's seen within the context of the family, the school, the peers, and then also in the wider community and nation. So when we do our data linkage, we really try to get different perspectives and different aspects from these various sources. So this is a bit, it's a lot of different information on this, but so when you look at it, so in the middle you see children. So again, this is thinking of those various spheres of influence. And so we have information on the child based on the EDI, the teacher-rated measure, which is done in kindergarten. We have information in our data linkage on academic scores in grade 4, 7, 10, and 12. We also have information on high school graduation, dropout, course failure, and whether they graduate on time actually as well. Then based on the middle years development instrument, we have information on their self-reported well-being, social context, and after-school activities. And then based on some of these administrative health data linkages, we have information on physician visits, hospitalizations, medication use, as well as from Immigration Canada. We have immigration variables if they immigrated on the age of arrival and family context and source region. In terms of the family context, so on the top right, we have information on parental health conditions, and we are particularly interested in mental health conditions of parents, family low income status, parent immigration background, and also self-reported parent-child relationship by the child. In terms of the school variables, we look at child-rated school climate and school belonging based on the MDI, school demographics, and cultural diversity in the school. And then finally, in terms of the neighborhood or community, we have socioeconomic characteristics, cultural characteristics, and also the child-rated neighborhood context, so what they think about the neighborhood. So this is kind of the background or context to it. The various data sources are the ones that Kim already mentioned. So from the Human Early Learning Partnership or HELP, here at UBC, we have the EDI measures and the MDI. Based on the Ministry of Health, we have medical services plan diagnosis. So when a child is accessing medical services, in terms of the billing code, we see what they accessed medical services for. We have information on if they're hospitalized, what were the conditions, subsidy codes, which we're using because families can apply for subsidy in the medical services plan if they have a certain income. And so this can be used as an indicator of poverty as well for those with the subsidy. And then we have information about prescription filling based on PharmaNet. Then in terms of the BC Ministry of Education, we have the information about academic achievement that I mentioned, but we also have information about the funding categories that children may receive for various special needs, which is also very interesting to have. Then in terms of Statistics Canada, we have information on their socioeconomic status, employment rates, education level, and various other variables such as ethnocultural variable. And then based on Immigration, Refugees, and Citizenship Canada, we have this information that I mentioned previously on the previous slide on age of arrival, and whether they are first or second generation, so whether the child was born within Canada or whether the parents were born outside of Canada, country of origin, so various aspects. And then in terms of vital statistic, as Kim also mentioned, and this is kind of the backbone of the whole data linkage, we also have information on vital statistic, including birth and death. So in terms of the linkage that we did, this database contains information from birth to adolescence for the birth cohorts that were born in 1990 to 2006. And these are over 400,000 children that we have in the data linkage. So these were linked through unique identifiers, personal education numbers or personal health numbers that each child has. And then the linkage was done by population data BC. And just to give you this kind of overview, so here you can see on the left-hand side so age of children, it starts with a birth, so we have vital statistics information. Then at 5 years, we have EDI teacher ratings, and so you will see different sample sizes, because of course we don't have information on all these children, over 400,000 on all measures, so it's kind of a, various different linkages. In grade 4 or at age 9, we have the middle years development self-report data, the same in grade 7. And then if they're still in the cohort, at age 18, we have high school graduation records. And then you see below, we have the various administrative health data and education data and immigration records, as well as neighborhood census data. So it's kind of just showing all at once. So just to give a very brief background, because there have been different webinars already done on the measures, I just want to briefly mention it if someone hasn't seen it. So the Early Development Instrument is a holistic questionnaire completed by kindergarten teachers across Canada. And so it kind of measures whether a child meets age-appropriate development expectations. And this was developed at the Offord Center for Child Studies by Magdalena Janis and Dan Offord. So this is the first page of it. So it's completed for all children in a kindergarten classroom in schools that are publicly funded, so public kindergarten, in February. And so these are the various developmental domains it's covering. So we have physical health and well-being, language and cognitive aspects, communication, general skills, emotional maturity, and social competence. And just to give you some examples of some of the subdomains, because I'll be talking about some of these as outcomes, these are the subdomains from emotional maturity. So the question would be, would you say that this child, and then for example for pro-social and helping behavior would be help someone who is hurt, and then a different response option, such as often or very true, sometimes or somewhat true, and never or not true. And then we also have hyperactive and inattentive behavior as a subdomain, aggressive behavior, and anxious and fearful behavior. And the same for social competence. We have various items covering these subdomains: overall social competence, respect and responsibility, approaches to learning, and readiness to explore new things. And so various ways are used to analyze the data. One approach is to look at vulnerability scores based on the EDI. So to be vulnerable means that a child is at increased risk of encountering difficulties in the school years and beyond. And so this is based on the first round of data collection, and when HELP determined the vulnerability cutoff scores to be those scores in the bottom of 10%. So later cohorts will then be compared to those with a cutoff of 10%. And we have seen over the last years that the cutoffs have tremendous predictive capability. So for example, being below the vulnerability cutoff in kindergarten has a direct relationship to children's scores in the later grades. And so EDI data can be linked at various levels. So at the geospatial level, it can be linked based on the child's residential address, so such as dissemination block or neighborhood level or local health areas. And just to give you an example, so this is actually for British Columbia using wave 6, which is, the most recent one is wave 7, but this is from the previous one. And here you can see, when you look at the different school districts, that there's variety in the percentage of vulnerability for children across the school districts. So on this scale, being 100% children vulnerable in that school district would be the dark red, and the lighter the better. So you can see there's a large vulnerability across these school districts. So that's one way of presenting data, which has been used for knowledge translation purposes, and just shows one way of presenting and linking. Another one would be to look at Vancouver Specific. So this is different based on the physical health and well-being scale. So this is based on the different neighborhoods in Vancouver. And I don't want to go into detail on this. I just wanted to show the different ways we have used the linkage. In terms of the EDI collection history, we are now actually completed wave 7, but this shows until wave 6, which we have in our data. It's over 247,000 children. And so it's also nice that you can monitor development over time, looking at differences over time. In terms of the middle years development instrument, this is a self-report survey for children in grade 4 and 7. It was developed here at the Human Early Learning Partnership and based on a community to action research collaboration with various stakeholders in schools, in the communities, and researchers. So really the idea was that this informs the stakeholders as well. So reports or results are given back to the schools. In terms of the dimensions, we also have 5 dimensions for the MDI. So it's physical health and well-being, connectedness, school experiences, use of after-school time, and social emotional development. And what is really important about this measure, so this is self-report of the child, and this is in line with the rights of the child that state that children have a right to give their opinion and be listened to by the adults around them. And children usually really enjoy responding to these items, so it's nice to get their perspectives as well. We also have developed a WellBeing Index, which is based on various of these scales, subscales, based on optimism, self-esteem, life satisfaction, health, and low sadness. And if you're interested in learning more about the MDI, there's a previous webinar by Kim Schonert-Weichel. But just to mention, so we have the high well-being striving from this well-being index, which is the part in green, medium to high well-being, which is the yellow color, and then low well-being. And this is also being then shown for the neighborhoods in Vancouver. So you can see the circles, and depending on the number of children in the data, the magnitude of the circle. And then for each of these circles, you can see very high, medium, high, and low thriving of the children. And underlaying it, you can see the socioeconomic status by neighborhood. So the highest SES would be the dark blue, and then average lighter blue, and lowest the very light blue. And as you can see here, mostly you see certainly an association in terms of high SES is associated with higher well-being, like a larger proportion of children thriving in this neighborhood. In terms of the MDI participation, we have over 80,000 children since 2009. And these can be linked at the person-specific data linkage. So this is why I wanted to present both. And so all the EDI and MDI contain personal education numbers. And these are the unique identifiers from the BC Ministry of Education. And so the PENs can be linked to the personal health numbers via a crosswalk. And this is done by population data BC. So going back to what I presented earlier in terms of the developmental trajectories that we have, I will just show you some examples of the studies that we have done. So in study one, we were interested in the associations of birth factors and socioeconomic status with indicators of children's early emotional development and mental health in childhood. And this was a population-based linkage study, which was recently published. In terms of the objectives, we were interested to examine the association of biological, sociodemographic, and SES factors at birth with the social emotional development in kindergarten based on the EDI, as well as health practitioner assessed mental health conditions. So these would be through billing codes from the medical service plan. And so the data sources that we used were based on vital statistics on the birth information, which included sex, mode of delivery, gestational age, the 1-minute APGAR score, and parent marital status. We looked at various EDI subdomains, some of the ones that you saw earlier, so aggressive behavior, hyperactivity and inattentive behavior, and anxious and fearful behavior. We used the medical services plan and hospital separation data and the ICD codes from ICD 9 and 10 to indicate depression, anxiety, attention deficit and hyperactivity disorder, and conduct disorder between age 5 and 15. And then we also used the subsidy through MSP that I mentioned earlier during the first 2 years as an indicator of socioeconomic status. And finally, Statistics Canada was used to have a block level income as a proxy for family income. This was also the one that Kim mentioned earlier that has been used. And it has been shown in previous research that it relates well to the family level income. So in terms of the result, here on the x-axis, you can see the block level income, and then on the y-axis, you can see the adjusted odds ratios. And this presents the EDI subdomains for aggressive behavior, anxious behavior, and hyperactive behavior. So the SES variable was derived from the block level census data on income quintiles. So the comparison or the reference group is the highest income level, so Q1. And so you can see, compared to children living in the highest income quintile at birth, those in lower income quintiles had incrementally higher odds for these various behaviors on the EDI. So this would be, the first residence that a child was reported since birth how this relates to outcomes in kindergarten at age 5. So a very clear gradient that is shown here. Then we also looked at some of these other outcomes. So we had the subsidy, as I mentioned, this is an indicator for poverty, separated parents or single parents, the lowest income neighborhood, the APGAR score, which is a widely used composite at birth. We use the 1-minute APGAR score, which indicates the color, pulse rate, reflex irritability, activity, and respiratory efforts. And so higher scores indicate better outcomes. And then late preterm was birth in the weeks 34 to 36, and then the delivery, mode of delivery. And as you can see from these, so these are the adjusted odds ratio. And for each of these, we have the outcome of the EDI, so teacher rating at age around 5 in kindergarten, so anxious and fearful behavior, and hyperactive and inattentive, but also the rating based on the ICD codes from the physician visits, anxiety and ADHD. So as you can see, various factors related to higher odds of teacher-rated poor mental health of kindergarten children, as well as health practitioner visits during age 5 to 50, such as having parents who were unmarried or the subsidized MSP. And I'm happy to talk about this more. I just wanted to present the type of research question you can do with this. So looking at birth risk factors and how this relates to various outcomes. So some of these implications are that social and SES factors that impede access to resources, such as money, time, and support, are adversely related to children's health. And these findings really reinforce that poverty early on in life should be a primary public health issue. So then in terms of study 2, so this was the first study was really looking at birth risk factors. In study 2, we were interested in the association of childhood social emotional functioning profiles at school entry, so based on the EDI, and how these are associated with early onset mental health conditions. So the objective was to see whether population patterns of children's social emotional functioning could be identified at school entry, so at age 5. And this analysis was based on a population sample of over 34,000 children attending public school kindergarten in BC from 2001 to 2003. So these were actually about 80%, more than 80% of kindergarten-aged children in BC at that time. And the second objective was then to examine the association of these profiles that are identified and the occurrence of 4 subsequent mental health conditions until age 14, namely depression, anxiety, conduct disorder, and ADHD. So the outcome measure was the count of these ICD codes captured in the provincial health insurance records based on physicians and psychiatrists and pediatricians. And this was a smaller subsample because we restricted the sample of children who had continuous health insurance data in BC for the 14 years following their birth, because we wanted to make sure that all of the children were in BC during this time period from birth to age 14. So what we were using is a latent profile analysis. The x-axis shows each of the 8 EDI social emotional subscales to create different profile patterns of social emotional functioning. And this is a person-centered analysis, so the latent profile analysis. And the advantage of this is to look at how these indicators fit or naturally group together based on common symptoms, and then identify the prevalence of those in the population. So if you think about it, so we might have found several groups of children that have high aggression, for example, but the first question might be, what are other common behaviors of children with high aggression? So let's say there's a group that has high aggression, but also high anxiety or aggression, anxiety, and what about social competence? So this is kind of grouping those children in these different, looking at different patterns of these indicators. So first we wanted to look at those profiles and then see how these relate to later or subsequent mental health outcomes. The y-axis are the standardized EDI scores, so above or below the mean, and negatively worded items were reverse coded, so anything above the mean is a more positive outcome. So in terms of the first profile that we found, so this is consistent with past research. Overall, most children, so 85%, exhibited overall high social emotional functioning on every of those indicators. Then we saw 2 other groups. So these children exhibited lower functioning and readiness to explore. So it's kind of a fearful indicator that has been related to future internalizing conditions in previous studies. Both groups also showed a relative strength. in that they did not have a very aggressive hyperactivity behaviors. And the main difference between the two was that children in profile 4 had markedly lower social skills and worse hyperactivity and attention compared to profile 2. Then we saw some additional patterns. So profiles 3 and 5 represent 16 and 8% of children. These children had relative strengths and readiness to explore, but weaknesses in social competence measures such as responsibility and respect, as well as hyperactivity. Again, the distinction between these two profiles, 3 and 5, was the severity of vulnerability in the social skills and aggressive hyperactive behaviors. The last profile group represented less than 3% of children, but these were rated extremely low across all aspects of social emotional functioning. So almost 4 standard deviations beyond the mean on aggression, for example. So here, all of the different profiles are shown. So you can see really the red one on the bottom stands out with the consistently low ratings of the teacher. So then we were interested, what is the association with socio-demographic factors? So when you look at this, so we will look at, for each of these profiles, what is the proportion of those children receiving subsidy, the sex, and the language minority. And we see an almost perfect socioeconomic gradient. So children receiving government subsidies were overrepresented in each lower functioning profile group. And you can see in the profile 6, 32% received subsidy. In total, 18% received subsidy in the sample. In the next step, we were interested in examining the relation of these profiles to the occurrence of mental health outcomes using zero-inflated Poisson analysis. The estimated population prevalence of these conditions was consistent with other studies for children in this age. So this is based on the physician records between subsequent after the ED until age 14. And so compared to profile 1 as a reference, which has the overall high functioning, profiles 4, 5, and 6 had the highest odds of mental health conditions, with children in profile 6 having over 7 times the odds of conduct disorder, over 12 times the odds of ADHD. So really what we found was we found distinguishable profiles of early childhood social emotional functioning. These were unequally represented based on the socio-demographic characteristics. And we do see that these school entry profiles are associated with subsequent mental health conditions. In terms of implications, so this showed that using a population level analysis, we could identify subgroups of 3 to 5% of children who were rated as having low social and emotional functioning across nearly all measures. And so these may particularly benefit from targeted interventions early on. Then going to study 3, which is now linking the EDI to the MDI. So this is looking at associations between children's social emotional functioning profiles at school entry and subjective well-being in middle childhood. And this is still ongoing. I just wanted to show again in terms of linkages that are possible. So we looked at the same profiles, kind of profiles using the EDI, and wanted to replicate the pattern with a new cohort of BC children. So these are now 2007 to 2012, the cohorts, over 17,000 children. And we were then interested in examining the association between the profiles and self-reported well-being at age 9. So the LPA results were comparable to the previous study, but they suggested a 7th profile, which you see at the bottom. So 6 and 7, orange and red, resemble the lowest from the previous study. And because this analysis was based on the most recent BC kindergarten cohorts, one thought was that this could be reflective of worsening trends in social emotional health over time, which we have also seen. And so then we looked at a bivariate analysis of how those profiles relate to self-reported life satisfaction, self-concept, and sadness. And so we see that this generally followed a gradient pattern with worse kindergarten functioning predicting worse well-being outcomes. So really thinking about the different types of assessments, so teacher ratings at around age 5 and how this relates to kindergarten, to middle childhood self-reports in grade 4. So we do see a very clear gradient for these outcomes. And finally, I just want to very briefly talk about some new studies that we're doing, or kind of a new research direction. which is using the social exposome framework. So this is very recent, and I just wanted to talk about this as a possibility for the future. So we're interested in the social exposome in child health and development. Exposome has been defined as a cumulative exposure over the life course that influences development and health from conception onward. And we are interested in epigenetic, which is a part of a suite of biological responses and technological advances that can be used to assess the exposome. So as you can see on the left-hand side, that, we talk about the technological developments and how these can be used then through data linkage to link it to extrinsic factors and intrinsic factors. And the goal is really to understand the biological mechanisms by which social factors get under the skin to influence child health and development, and then to apply this knowledge to the development of interventions and policies to reduce disparities and optimize the health and well-being of children. So really the idea is to identify contextual factors that affect healthy child development, and then understand the biological underpinnings and the responsiveness to interventions. And so the way we are doing this is linking the child study, which is the largest multidisciplinary longitudinal birth cohort study in Canada. And for this study, we're linking data from Vancouver only. So this has been done in various provinces, but we're doing the linkage with population data BC, so for the Vancouver specific data. And so in the child study, they collected data from 18 weeks of pregnancy up to 8 years of age. So right now the 8 years of age data collection is ongoing through questionnaires, interviews, doctor visits, and collection of biological samples. And so we are particularly interested in the biological samples, and then link these to population level data on child development, including the EDI, administrative health data, and administrative education data. And so really we're interested in it's a phenomenon called biological embedding, that early life environments predispose children to later health and developmental outcomes. So we will use the epigenome, microbiome, and metabolomic data that is based from the child study and currently being analyzed, and then link this to those population level data. So what we're interested in is really the relationship between the early life environmental exposures, these biological measures, and then subsequent child health and developmental outcomes. And just kind of as at the end, just a very brief discussion of various challenges that we have encountered or people may encounter when they use population level longitudinal data linkage. So one of the things is, of course, the data coverage. So depending on what you're looking at, you may have different data coverage. So for example, for the EDI, this is only collected in public schools, and the MDI only in select school districts at this point. So even though we talk about population level, it may not be coverage for the full province of BC. So having data on about 500,000 children does not mean that you have complete data on all the various measures that we're using. And another one is the linkage rate. So sometimes, if EDI data are collected in a certain year, this might not be in line with the years that MDI data are collected in that school district. So this always depends also on data collection. Then there's potential trade-offs. So it's a very large group of people, but sometimes you don't have the amount of information we would like to have. So it's really kind of quantity versus quality. One of the examples would be the measure of SES. So some of the block level income may have masked variability within a block, for example, that we mentioned before. Although, as I mentioned, previous studies have shown it's a pretty good proxy. Another one would be data quality versus and validity. So for example, using those ICD codes that I mentioned. So this is based on billing information rather than having a clinical assessment or diagnosis, which is often done in specific research studies. And one of the issues, of course, is there may be unequal access to medical services. For example, we know there's an underutilization more for those with lower income and non-English speaking families. And then these data are not collected for research purposes, so these are secondary data that we're using. So some of it may not be how you would, kind of in the ideal research world, how you would like to collect your own data. Another one is ethics and privacy. Of course, these are very sensitive information, so one has to be very clear about who can access data. And for example, with Population Data BC, people have to be physically present in Canada to access these data. And finally, data access and cleaning and deriving of variable. So the time saved in recruitment and data collection sometimes is gained back by obtaining, the data access and then the cleaning and going through the various steps with the data stewards. However, there are lots of opportunities that come with these types of population level longitudinal data linkages. So this includes the representativeness, and the ones that I presented is almost 500,000 individual children. We have diverse modes of assessment, so we can look at development from various sources, including administrative records, health, education, immigration. We have the survey responses based on teacher ratings and self-reports of the children, and we have the neighborhood census data. We also, when you think about it, when I talked about this bioecological model by Bronfenbrenner, we have information on the various ecological contexts, such as the child, family, school, and neighborhood. And then finally, we are covering multiple developmental phases, so from birth to early childhood, middle years, and adolescence. So these are some of the funders that I would like to acknowledge and some of the collaborators. And I would be very happy to open this for discussion. Thank you very much. And actually, one last thing, and we're always very happy about collaborations. So please send me an email. As I mentioned, you can't access the data from outside of Canada, but we're always very happy about collaboration of using our data. Thank you so much.
Great. Thank you so much, Anne. And Kimberlyn, it's very inspirational both to hear about the Population Data BC and that infrastructure, and then the work of the Human Early Learning Partnership that has really been on the forefront of the development of population level measures for children with the EDI and the MDI. It was a really rich set of information. Let's please open up the conversation now for reactions from the attendees, or specifically questions that you have. I think that you could use the flag button and we could take you off mute, or you're welcome to enter your question into the chat box and we can read it out loud for everyone. And while we're giving people a little bit of time to think about that, I know there were a few questions our team had here that I just wanted to go ahead and take advantage of the fact that I have my mic on, to ask a little bit more about the mechanisms for linkage. And I understand the personal education identifier, the PEN, is key to link between the EDI and the MDI. But could you tell us a little bit more about those mechanisms to link with vital stats and health and family support, whether there's probabilistic matching, or what are those mechanisms and those variables that you're able to use to make those unique links of people? Could you talk, I don't know if that's a question for Anne or for Kim, but just if you could tell us a little bit more about that.
Anne, do you want me to take that?
Yeah, sure, that would be great. I think you're the expert on this, of course.
Okay, so I think one important piece of this goes back to the comment I made that we have a spine for linkage. So that means that we have a full list of people who are in British Columbia, and then another way to think about this would be hub and spoke. So when data sets come in, we link them to that one central place, and then by definition, once it's linked to that central list, it means that we have then the ability to connect other data sets together. So for example, if we linked the physician payment information to the central spine, and then we linked the EDI to the central spine, then it is clearly we have a path to say that we have been able to link the EDI and the physician data, though they haven't been directly linked per se. So what we do is when we receive data from data providers, we separate what we call the content and identifier fields, and that's a privacy protective measure. It also means that when people are actually conducting data linkage, it's without content information. So we know that somebody's in a file, but we don't know anything about scores on the EDI or any other characteristic, depending on what the file is. We use any information that is available for linkage. So our spine has a personal health number because it comes from the health sector, but it also has first name, last name, a full birth date, sex, and also the 6-digit postal code, which I indicated in BC and all of Canada are pretty small area. So they're actually reasonably good linkage identifying fields. We use a combination of probabilistic and deterministic linkage methods depending on what files we're linking. If we're trying to link education or early childhood and health data that doesn't necessarily come with the personal health number, the health specific identifier, then we definitely use names and birth dates for that and do probabilistic linkage.
Mm-hmm.
And then we have very typical linkage setup where we do nisus coding. So you take phonetic spellings of names, you create nicknames, and look for switches in the month and year of birth date and all of those other things that you would normally do. But that's kind of the basic pathway.
Thank you. We have a question from Nicholas Kasavik, and the question is data access available for program development and or service provision, or is it strictly available for research?
At this point, the requests that we can accommodate are those that come from people who have a university affiliation and that have a proof of peer review and proof of ethics review. So if you were doing some kind of program development that met those criteria for some reason, then we would be able to consider the request. I am hoping that that will be expanded over the coming time period because, I mean, it's just in the general nature of democratization of access to information. But that's where we are now.
Yeah, it's an evolution. Thank you. And thank you for that question, Nicholas. Another question we have from King Lee, and I apologize if I'm mispronouncing anyone's last name. How could early warning signs among poor support and interaction among parents during prenatal and delivery service data be linked for the early identification and follow-up to prevent child maltreatment when children are 2 years old? Let me just read that again. I might get a better flow here. How could early warning signs among poor support and interaction among parents during prenatal and delivery service data be linked for the early identification and follow-up to prevent child maltreatment when children are 2 years old? How could early warning signs amongst, for interaction among parents?
It's very specific about the 2-year-old as well. Can you just read it one more time? Because, I mean, yeah.
And King Lee, if you would like to be unmuted, we could do that for you as well. I think, Jason, just to make sure I'm, articulating the question that you have. Jason, do you see King's name under attendees that you could unmute? I'll read it one more time. How could early warning signs among poor support and interaction among parents during prenatal and delivery services be linked for the early identification and follow-up to prevent child maltreatment?
I think it's a very specific research question. I'm not sure if this could be directly answered, and please step in, Kim, but so interaction of parents, we're looking at administrative health data at this age. It would be only administrative data and, maybe link it to census data, of course, in terms of identifying who's poor. But in terms of the interaction among parents, so the only where we have in our data linkage right now is looking at relationships with parents of the child would be with the MDI. So this would be much later. You could, of course, look at warning signs in terms of certain outcomes, in terms of administrative health data, in terms of outcomes of early outcomes based on the medical services plan, for example, certain types of condition and how these relate to early SES factors. But I'm not quite sure about the interaction with the parents.
Yeah. Good. I was also wondering if there was an update, and this may not be the area that you work, so forgive me, but I know that we've talked about the EDI and the MDI, that there are also plans for the TDI, the Toddler Development Instrument, as well as potentially a YDI for high school age children, and I'm just wondering how close those are to being implemented or at the population level for linkage. Where are those?
So can you still see my screen?
Yes.
Yes, so I just went to the next slide. I just had this just in case it came up, and I wasn't sure if we have time. But certainly, so the TDI is at about 18 months of age for children, so much earlier. And then the check is another measure that is currently being implemented. So that's both of them are in pilot stages, but now I think the check is currently being implemented for the first time at population levels as well. And then which is not on here would be the YDI. As you say, this would be for later in grade 10, so youth development instrument. And so both of the TDI and check, we're actually planning, so the check and the EDI are already being linked, so you can look at more of the contextual factors. I'll just show you some of the constructs on the TDI and check. They actually match each other. So for the TDI, it would be usually at the immunization visit of children at 18 months. And the check would be the parent or caregiver when they come to school, to kindergarten, and enroll the children. And so they are asked about child, parent, and adult at home interactions, social play, outdoor play, and screen time, sleep, nutrition, dental care, so various aspects, childcare and access barriers, child family resources, neighborhood safety, social support, family dynamics, parenting beliefs, parental well-being, and demographic and SES background questions. So, I mean, if these were available at the population level, of course, some of those things could be addressed, also with regard to the previous question. But right now, they're still in developmental phases. But yeah, as I said, we actually already, so the check, we're trying to get it linked to our larger data monitoring system.
Yeah.
And I can leave those on if people are interested.
And Nicholas, the first person who asked a question, said, "Thank you. I appreciate the diligence for privacy and protection on the data as a significant part of the process for data sharing." Lynn Gilbert is asking, any data links to overweight/obesity trajectories?
So in terms of obesity, if children see a doctor, there's a billing code for obesity that is being used. One of the issues is that we know we actually are working on some research around that. One of the issues we know is that often it's not an assessment of obesity, so it's not even using the BMI, but more looking at a child and giving the ICD code. And we also have some questions about perceived weight, self-perceived weight, or body image on the middle years development instrument. So again, these would be different proxies to look at it. So one would be the physician ICD code, and the other one would be self-report on children's body image.
Yes. Another question, oh please.
And just to mention, so we actually see using those physician codes, we do see that early child obesity is related to EDI outcomes, so to poorer EDI outcomes, as well as larger odds of mental health conditions later on and lower education outcomes. So if you're interested, please send me an email. I'm happy to share the results with you.
Another question that we had here internally would have to do with how the effects of place and neighborhood conditions might come into the mix in terms of the stated linkage and looking at the relationships. You know, I know that you all have done a lot of this work looking at neighborhood conditions as it relates to child well-being, and we in the U.S., particularly with Efrain Aguilar here at our center, who has replicated an index of neighborhood risk. You know, we know that things like poverty have a strong relationship to child development, but when looking at the level of neighborhood risk that might, as an index that might include things like poverty, we see that at a neighborhood level, some neighborhoods can buck the trends that might be predicted for individual research in terms of some neighborhoods with higher level risk might actually have children doing better developmentally or the reverse. And so those are the outliers, but in any case, it's an interesting area of study, particularly around community engagement for those communities to understand what are the resiliency factors in their community allowing them to buck those trends. So I'm not sure how that really plays in to some of the research you're doing, but just wanted to raise that up and see what your thoughts are.
Yes, so we're actually very interested in those as well. We call them the off-diagonal communities. So, you know, you would predict more negative outcomes, but we often see quite positive ones. So those are the off-diagonal ones. And we do see that as well with the MDI. So this is grade 4 and grade 7 self-report. And they report on the assets in their neighborhood as well. So this would not be the administrative data, but it's actually self-report and how they perceive the neighborhood and the things they can do in the neighborhood. And so we do see that those are very important aspects on the child development. So it's not just the SES, of course, but there can be other protective factors. And, it's, of course, we can't really make a causal claim on why that may be, but for some of those community, we have done some preliminary work on identifying what might be different, and it could be some very involved after-school community programs or various things like that. So that's certainly a very interesting part of what could be protective factors that could be implemented at the neighborhood level.
Fantastic. And Kim, our speaker, is passing along a question that came from Shabina Hussein. Hi, this is Shabina in Mount Lake Terrace, Washington. My question is about children who are not enrolled in kindergarten, even though they should be in school. They are not due to some family issues, etc. Is data being accessed through home visitation by social workers or family support workers, etc.? And this would probably be for the EDI, are those children included in measures like the EDI or the MDI that are typically collected at the school? Do you know, Anne?
Oh, I thought you said this was for Kim. Yes. So actually,
go ahead.
No. One of the things is, and this is why I thought it was a very good point from Kim as well in terms of the spine. So who is actually present in BC? So we are certainly interested also in those children we don't see in our data, because as I said, so the EDI is in public kindergarten only, and so this is not. So it's not required. So not all children have to go to the kindergarten. So, we have about 80% of the children in BC through the EDI. And the MDI, it's a consent. It's passive consent by the parents, but also the children can opt out. So of course, we're not having all the children, and we may be losing some of those that may be especially vulnerable. And so one of the things is that you can do is having the spine of who should be in your data, and then looking at various measures of how are those different that are not in the data to those that we have in the data. Maybe based on SES, for example, language, background, those kinds of things. And so they're not specific extra visits, because this is really more like a monitoring system, but it's definitely for us as researchers also very interesting to see who are those. And the same in the school, like who's dropping out early. Because, then we don't have them in our monitoring system. If they drop out in terms of the education records, we don't really see it. But then we have this spine of who should be in the education system. So we can see who are the ones we don't see for later grades anymore.
That's right. Yes, and for us here in the United States at UCLA, our database has about over 300,000 children now in it. We're not, of course, national. We're not even statewide in any state, but we certainly have strong saturation, full public school participation in a number of the communities, and countywide in some large counties like Orange County and nearly in San Antonio. But even for us in the U.S., the target is the school system. We are able sometimes to reach charters and private schools, but we're looking for a universal measure and a standardized way of collecting that. And so we have not been able to reach, children who are not enrolled in school in kindergarten. So it's designed to be census of all children, but there are certain children that aren't reached for us in our implementation as well.
Yeah, exactly.
We have another great question here. Is there any population data that is collected specifically about fathers during perinatal period? If so, which entity is collecting it? That might even be for Kim, but it's about the fathers, and any data collected about fathers, perhaps more generally about fathers, but also the question was specifically during the perinatal period.
So fathers is an interesting thing. It's Kim, I'll try and obviously jump in if you have something to add. But so there isn't, as far as I know, any specific data collected from or about fathers during the perinatal period. There's certainly information about mothers collected. We have a actually quite good, well-developed perinatal database registry, but I don't believe it asks specific questions about fathers. We do try to make sure that we link babies when they come in to both the mother and the father. The father linkage can sometimes be a bit trickier because fathers' names are not necessarily required on all birth certificates, which is one source of linkage. So even the ability to create full families, we know that there's some holes in that, although we do the best we can in that. But yeah, so it's definitely much trickier on the father linkage than the mother's.
Yeah. Great. And then we'd have just a good question for everybody. Are the slides from this presentation available to be downloaded? The answer is yes. And I think Jason, he knows the mechanism. We have to thank Jason for helping to coordinate this and make this technology available. So Jason, if you're there, what's the best way for everyone to access the slides?
I'll just have Ann and Kim send me the slides that they used for the presentations today, and I'll put them on the LCRN website, which is lcrn.net, and I'll type that in the chat function as well.
Great. And right before we close this, we'll put that slide back up just in closing. We don't have to do that right now, but so that you can see the website again and Jason's email. Great. And really appreciate the questions that have come in so far. If there aren't any other questions for now, really want to thank Kim and Ann so much for your time and this thoughtful presentation. It's been really informative, made me a little bit jealous. I think we all want to put grants in to come to Population Data BC to be able to potentially explore the resource there. And so let me just double check that there aren't any other questions shown up that I've missed. There's some thank yous coming in from the audience, and we concur. So I think we'll close here, give everybody a little extra lunch time. And again, thanks so much to Kim and Ann.
Thank you very much.
Have a great day, everyone. Thank you for joining.
Thank you. The same to you.
And Jason, if you could put up that final slide for LCRN, just in case people would like the website. Thanks again, Jason, for your help today.
Yep, sounds good. I just put it up.